Okay, good evening and welcome. I am Lauren Gates, your host of this evening's Airway Health Solutions conversation, featuring the fabulous Dr. Jasmine Elmore. Tonight's topic is Upper Airway Resistance Syndrome, or UARS. And I am so excited personally to learn from you, Dr. Jasmine, because I have so many questions about this. And thank you so much for coming on tonight. I know we've both been so excited all week, and here it is. So welcome, welcome.
Thank you, Lauren, for having me, Dr. Ben, the whole Airway Health Solutions team. So excited to be here. Thanks so much for the opportunity to chat with everyone. I am a board certified pediatric dentist and airway sufferer who started studying all this stuff. And here we are. I suppose, Lauren, you're back. Oh, you're on mute. We can't hear you. Lauren, you're muted. You're muted.
Sorry, I said I was so excited. Apparently, I got kicked off. I was were you able to share a little bit?
Yeah, I just basically said I was an airway sufferer who started learning all this stuff. I've got 1 degree in breathing behavior, another certification in myofunctional therapy. So I went all the way down the rabbit hole, as they say. And yeah, I'd love to chat with people after this about a bunch of different topics. So.
And I was also really impressed because I did check you out, snoop a little bit on you, that you have your own scholarship. I thought that was so great. So I'm just going to give you a little shout out. You have the Dr. Jasmine Elmore Scholarship from your alma mater, Virginia Commonwealth University. Just want to tell us a little bit about that and what inspired you to do that?
Oh, well, you're quite the not amateur sleuth. You're quite the fancy sleuth, but yes, I actually have 2 scholarships at my dental school. One is in my name, and it's for students who really connect with their patients and make a difference outside of just drilling teeth. People who can see the person attached to the teeth, not just the teeth attached to the person, as my mentor, Dr. Barry, likes to say. And then I have one in the name of one of my mentors and the guy that really made dental school transformational for me, one of my professors in dental school. And his scholarship is along the same lines, but it's really about empathy, soft skills, and things outside of the drill and handpiece. So we have those 2 scholarships offered each year, and we've been doing it about 5 years now. So it's been fantastic.
Wow, wonderful. You never cease to amaze me. So let's start off, because we have a really close to 400 people registered tonight. I know a lot of people couldn't make it tonight, but they wanted the recording. So let's get to it, because we have a ton of questions as always. So we'll do your part of it just to get an overview of UARS, and then you can feel free to use the chat for your questions, and we will do our best to answer them all. So if you can just go ahead and share your screen.
Yes, I am. It's been a while actually since I've been on Zoom. So
okay.
Figure out where my share button is. There we go.
Okay.
All right. So, and I put this together just for you, Lauren, this presentation. I kind of threw it together.
I don't see your screen. 1 second.
Make sure I am sharing right now.
There we go.
You see my screen? Excellent.
Yep. Thank you.
So this will just be a brief, very informal overview of upper airway resistance.
Exactly what we want.
All right, what is it? Why should we care? Why are we best positioned to help as dentists? And this is kind of a big compilation of a bunch of stuff. So hopefully you guys follow me as we go along. Happy to answer any questions at the end. So disclaimer, as in all presentations, this is not medical advice, and we're just sharing some opinions, some information and education. And yeah, I just got to get that disclaimer out of the way so we can move forward. So I like to usually start off presentations like this saying that if you've ever been to a restaurant and you're about to sit at a table and it's not prepared yet, right? You've got a busboy or a busgirl who's going to prepare this table. The reason is because in order for you to really enjoy your meal, you're not going to eat at a table if it's already dirty, right? If someone else's stuff is left behind on the table. And I think that my pastor uses this analogy in church, and I think it applies here when we do presentations, because when we're learning a new topic, if we don't kind of clear the table and really get the air open on all the controversy and all the things going on and all the barriers, then it's almost like we're eating at a table that has all this baggage on it. So we're going to kind of clean some of the mess up first, and then we'll start chatting a little bit about upper airway resistance syndrome. So This slide is borrowed from my friend Roger Price, and I love this quote. It says from Einstein, "The thing that gets in the way of my learning is my education." And I love that, because all too often, it's the thing that gets in our way of really learning is all the things we already know. And along that same vein, when it comes to learning new things, especially in medicine, it's hard. We spend all this money, we go to dental school, we go to hygiene school, we go to all these schools, and we have this education, knowledge, and standing, and then we find out that, oh no, the things that we're here to treat, the symptoms, are actually just the warning signs. They're not exactly the problem. But the problems are seen as the symptoms, but the symptoms are really just what shows. And so one of the things that we're going to talk about today is that the problems and the symptoms are not the same. And it requires a change in shifting in thought a little bit to really understand these things. And I really think, Lauren, that you guys, Dr. Ben, you guys do a really great job of talking about what are symptoms, what people are suffering with, but really what's the root cause and how we can make long-term success with you guys as a client. I think is fantastic. So another stumbling block is that the difficulty lies not so much in accepting new ideas as so much in escaping the old ones. So keep that in mind as we go through this 20-25 minute presentation today. So again, borrow this from Roger, but I love the way he has this common challenges and not just understanding upper airway resistance syndrome, but obstructive sleep apnea, snoring, mouth breathing, really just this whole gambit of issues that really has gotten a lot of new attention, but something that's been here for a while. So, you know, you're not a doctor. Why are you talking about this? You know, what does this have to do with teeth? There was one of the questions, Lauren, you showed me that someone said, how do you incorporate this into a standard general practice? We're not going to necessarily answer that today, but there are challenges in bringing these things up to patients who this is their first time hearing it, right? You know, are you specialized in this field? Are you stepping outside of your expertise? I just came here to have my teeth fixed. These are all the things that we really want to make sure that we know we're clearing the table. We're moving all the stuff, getting all the baggage out of the way. So we know kind of what we're stepping into. But I commend everyone here. I can't see you guys anymore, but everyone here who's learning and trying to understand things to make their patients' lives better, their family members' lives better. So even though we have these challenges, we can move forward with, you know, with them still there. So Roger keeps the slideshow going, but we'll keep going forward, Lauren, since we're short on time. So what is upper airway resistance syndrome? I think the simplest definition is it's a resistance in the upper airway, right? So let's talk more about that, but let's first talk about who discovered and who coined this term, upper airway resistance syndrome. Dr. Christian Gimeneau from Stanford University. For those of you who love Dr. Sarush Zaghi, as I do, from the Breathe Institute, this is the guy who trained Dr. Zaghi. So I know a lot of people here think Dr. Zaghi is the GOAT, and I'm not going to disagree with that. Love him so much. This is the guy that made the GOAT. So I don't know what the dad of the GOAT is, but that's who this guy is. And he, along with another doctor, also coined the OSAS terminology as well that we're familiar with. And so Dr. Gimeneau said that he noticed abnormal breathing in some of his patients, but they didn't meet the classic description of oxygen tension drops, as was what was going to be defined with the OSA. With OSA, we see this oxygen tension and this drops in oxygen, but there was a subset of people who had abnormal breathing. They didn't meet the criteria, but something was not right. And so in that discovery process, he coined the term upper airway resistance syndrome. So that's where that term comes from. So for him, what did this abnormal breathing look like? Okay. There is I think, Lauren, I'm going to give you the link to it. Dr. Stephen Park has a podcast that he did with Dr. Gimeneau a couple of years ago that deep dives into all this. I encourage everybody to check it out. It's under an hour. It's a great listen. But Dr. Gimeneau says in there that the adults had fatigue, memory issues, concentration gaps, headaches in the morning, muscle pain, tooth grinding. And then there were children who suffered from this abnormal breathing as well, right? Didn't meet the criteria for obstructive sleep apnea, but something still was not right. And for those children, he noticed hyperventilation, inattentiveness, enlarged tonsils, and really small nostrils. And so he started to paint this picture for these sufferers who didn't fit in the box of obstructive sleep apnea, but something was going on. And so that's how he defined upper airway resistance syndrome. So hopefully that makes sense. So for those of you who are more graphic learners, I've got a couple of extra things for you guys. So these slides come from the SAT screen. This is not an ad for SAT screen. They're not paying me, but I love this slideshow that they gave me access to when I was early on in subscribing with having a high resolution pulse oximeter. For those of you who don't know what that is, the simplest way to describe it is this little thing you see here. It looks like a watch, has a little finger gauge on it, and it has a higher resolution way to observe your oxygen levels, okay? So SleepSat goes into some of these differences to kind of hopefully clear them up for us and give us some scientific descriptions with them as well. So SAT screen says that many patients are on the fence about screening and getting treatment for sleep-related breathing disorders. And so therefore they have this at-home way to find this out. Again, not a commercial for them, but just this, these are their slides. So I'm setting you guys the stage for them. So you'll see in a minute that on the SAT screen, there's 3 things that are going to be measured on the left side of the screen that I'll show you guys. We have respiratory disturbance index, respiratory event related arousals or RERAs, and oxygen desaturation index. We won't get into the details of these, but all you need to know is that these 3 parameters are measuring what's happening with our breathing from the standpoint of oxygen, okay? And so this SAT screen, this particular device is going to measure this and use this as a way to put people in boxes. Are we upper airway resistance syndrome? Are we sleep apnea? Are we normal? Are we low risk? Okay. So for the classic apnea review, because we're practitioners or we work in an office and you need these numbers because this is how we bill, right? So we need to know what the normal numbers are. So the guidelines for obstructive sleep apnea, you would see an RDI, a respiratory disturbance index, under 5 would be normal, 5 to 14 with excessive daytime sleepiness. That's what EDS stands for, excessive daytime sleepiness, or some comorbidity would be considered mild. Moderate would be an RDI of 15 to 30, and then severe with an RDI over 30, okay? So a symptomatic patient who does not fulfill the criteria for OSA may have upper airway resistance syndrome. I hope now from a few slides ago, that makes sense for SAT screen slides, okay? So let's get into this report. So this report, we don't have the time to get into all the details, but I want to show the highlights because they do a really good job of explaining what's the difference between low risk or no risk, upper airway resistance syndrome, and obstructive sleep apnea, okay? So the things that we'll pay attention to, all right, are gonna be on the left side here in our RDI column, okay, where we're looking at the RERAs, we're looking at the ODI, and we're looking at the RDI, which is that compilation of all those things calculated together. There's cycling time and cycling severity and saturation and some more complex things, but we're gonna skip them for now, okay? So we're gonna be looking at this column here as we go through a couple of examples, okay? So again, as I mentioned, low risk, upper airway resistance syndrome, and obstructive sleep apnea. We're going to take a quick look at what those things would look like if we had a high resolution pulse oximeter on at night to monitor these things, okay? So for low risk, few to no events of oxygen going down, right? Normal oxygen levels and few to no arousals. This is considered normal. The RDI less than 5, as we saw a couple slides prior, and then all of the little complex things that we're going to not pay attention to right now, but just that RDI less than 5, okay? With few to no arousals or awakenings. So what that would look like on the pulse oximeter reading on our RDI column here, we're at 0, okay? And then I want you guys to look down here where we have what's going on with our oxygen levels, and then we have our pulse rate, our heart rate here, okay? And so you can see that things look pretty steady. That line looks pretty normal or pretty stable, let's say, okay? So that would be considered a low risk individual, all right? So now let's progress now to upper airway resistance syndrome, where we went from no breathless or desaturation oxygen drop events to now a few events, minimal drops in our oxygen saturation with frequent arousals, okay? So now we're gonna have events that we see, right? Our RDI is still probably gonna be low. It may not be over 5, so we're still in that normal range on the RDI column, but we're gonna notice, again, we're skipping some of the complexities, but we're gonna notice this little bullet here. The clinical workup would be suggestive of excessive daytime sleepiness and fatigue. Snoring may or may not be present. Flow limitation is suspected. And in this case, flow limitation just means we're flowing along in the airway and there's some limits, there's some barriers to making that smooth. And then the actual raw data, which we're gonna look at right now, is gonna show a couple of changes in the arousal of our autonomic nervous system, okay? And of course, I didn't say this earlier, but we're ruling out other sleep disorders. There's like a bunch of other sleep disorders. We're assuming this person has tested negative for narcolepsy, all of those things, okay? So now in the upper airway resistance syndrome, a normal RDI doesn't necessarily indicate that there's no sleep-related breathing disorder because of the fact that our RDI is low, the changes in our oxygen saturation are minimal because our heart rate is doing the work to take advantage of this opportunity because we're healthy to bounce back. Oh no, the oxygen's dropping, let me step in, the heart saying, and make up for this difference. And so because the heart acts so quickly, the oxygen levels don't drop. But what we would see is the heart's activity. We would see the heart rate spiking. So in this sample, now look at our heart rate. It looks like we're on a Peloton bike, but we're sleeping, okay? And so again, the RDI is low, the oxygen drops are infrequent, but the heart rate is pushing overtime. We're at Orange Theory, we're somewhere working out, okay? So let's look at a full screen again of this to hopefully tie this together. So here's our RDI column here, again, very, very low. And again, I apologize for skipping some of the other complexities on here. I wanna get into them, but we're kind of speeding through this. But I want you to notice that the oxygen level stays pretty again, stable, but look at the pulse rate. It is off the charts. It does not look like that previous example at low risk, okay? So what exactly is happening here? This is the reason I'm showing you the SAT screen sleep SAT, because they do a beautiful job of explaining this. And this is all information that they give the patients access to, which I think is fantastic. So in upper airway resistance syndrome, think of a well-tuned car where the vagal tone is the accelerator and your autonomic nervous system is the braking system. So in the case of upper airway resistance syndrome, we're trying to keep this car at, in their case, 95 miles an hour while driving over a hill all night long. And in order to maintain that speed, we're switching from vagal tone to autonomic nervous system, vagal tone to autonomic nervous system over and over and over and over again. And what happens over time is that we start to wear out the accelerator to that car, right? We decrease our vagal tone. Our engine kicks into overdrive. We call that sympathetic overdriven. You know those people. I'm one of those people. Always in sympathetic, right? The meditation things work temporarily, but go, go, go. That's when you're sympathetically overdriven. We're going to see that over time. And our brakes are going to wear out. Our brakes, again, are going to be the autonomic nervous system. We're going to overheat, and our parasympathetic sympathetic response is going to be thrown off, okay? And so I think this example using the car really explains it really well of what is happening in upper airway resistance syndrome, that we're having an issue with our vagal. Yes.
I'm going to interrupt with just a question because I think it's important during this. It's a great analogy, but is that what nighttime sweating comes from and the heart beating faster?
Yes. Well, I'm saying that yes, very, very generally, but yes. So there are going to be the sweatiness is a symptom. So again, from the slides previous where we're talking about what's a symptom, we would see excessive sweating. We would see tossing and turning. We'll see a lot of different things that are indicative that we are giving effort. There's a respiratory effort that's happening. And so yes, excessive sweating is definitely one of the things that we'll see. There's a lot of different things, Lauren, but yes, absolutely. And so those are, again, the symptoms that we'll see as a result of this. Great question. But I love this analogy to imagine this car that's working in overdrive. So if we zoom in on their analogy here, we have the high vagal tone causing a spike in our heart rate, right? We're stepping on the gas to maintain the speed. But when the respiratory effort normalizes, our autonomic nervous system, the parasympathetic sympathetic response, is going to adjust until it doesn't adjust anymore. And that's what happens years later. There was one of the questions you sent me, Lauren, where people said, how do we stay normal or compensating for so long? And then all of a sudden, it's like we fell off a cliff. Well, that's because the body's compensating, and it's like a bucket, right? And at some point that bucket fills up, and then the bucket is not of any use anymore because it's too full. So at some point the body says, we've been doing this for a long period of time. This didn't happen yesterday, right? We've been over here for so long that now we're going to make some changes. The vagal tone is going to wear out. Our heart rate response diminishes and the oxygen levels drop now because our heart rate was jumping in to help our oxygen not drop. But now our heart rate has decided that, hey, that's normal. This is normal. There's no need to jump in. This is what we've been doing for years. So now we're not going to jump in as much, and you're going to see the oxygen drops. Okay. So wrapping this up with the obstructive sleep apnea. So how does upper airway resistance syndrome, how is it different than obstructive sleep apnea? Well, you can see here in the complexity of things that we're going to skip, but basically what you can see is now we have these events. Now we're seeing the oxygen events that we did not necessarily see in the upper airway resistance syndrome, where our heart rate was jumping in to save us, jumping in to save us. We've now compensated so long that it's our normal, that the oxygen levels show now. The oxygen drops, show now. And so we have many events. We have desaturations and a bunch of other things that I won't get into at this moment, but that's kind of how we get more complex. I hope that makes sense, Lauren.
It does.
So people asked a lot of questions about, what does this mean? How do you fix it? So that in and of itself is a 3-hour conversation. So keeping in mind our time, I wanted to bring to you guys' attention Dr. Stephen Park's website, because I think that he does a really good job of explaining this in a simple and easy way to understand. So if you go to his website where it says search blog, type in sleepiness. And when you type in sleepiness, you'll pull up a blog that he has where he talks about some of the simple ways that you can help yourself if you're struggling with upper airway resistance syndrome, that are simple, that are inexpensive, that are conservative. And then after we've exhausted those options, then we can move forward to the more aggressive options, right? So the analogy that he uses is sleepiness. And he says in this excerpt that I have here, that before starting any treatment, he believes that you should exhaust your conservative options. I tend to agree with that. I think most of our patients, not all, but most patients want to start off simple and easy, prove that they can do the simple things, because if you can't do the simple things, Lauren, you have your own blog of how difficult it is to keep up with the appliances. It's a lot of work. And one easy way to not have a patient battling with you about the work is to set the stage very early on that you got to get the sleep on time. You got to get the appropriate amount of sleep. We'll clean up the sleep later, but you got to get the appropriate amount of sleep. Light. One of the things that was a big thing for me is getting sunlight, natural sunlight early in the morning, opening up those blinds. I was able to feel better in like 8 days just by making a simple change as opening the blinds, not putting on my sunshades when I drove to work. Eliminating toxins. I'm not going to go into all the details about toxins. I have a degree in nutrition, but that was many moons ago. But we have lots of different toxic things that are in our environment, in our bodies, that we can eliminate. Eating. As somebody who gained 35 pounds over the last couple of years, I think I'm an expert on eating, but eating the right things, losing some weight, what we ingest, clearing our nose, exercising outdoors, sleep position, which is very important, and stress reduction. So if you've got 3 minutes to talk to someone about how can I help myself with upper airway resistance syndrome, very easily and very simply with sleepiness. And again, if you go to his blog, he explains that. Now let's go a little complex before we end, Lauren. He takes it a step up and talks about this compass, okay? So what is compass? He says here that there's no magic bullet, that there's multiple options for multiple people, and they're in no particular order. He just wanted to have this easy to remember compass, which I love. Conservative. I could talk to you for 10 hours about conservative, but let's just summarize that in saying, if our autonomic nervous system was one of the issues we mentioned in upper airway resistance syndrome, then we need to find ways to decrease our stress or at least improve our response to stress. And that means a lot of different things for a lot of different people, Lauren. I'll leave that at that, but we can chat about that later. Oral appliances, airway health solutions. Here we go. Let's get those oral appliances in there. We can widen the jaws. We can really dig deep into some of the root causes, which many of us believe to be that our jaws are small, that we had some issues in development, whether that was in the gestation phase or whether that's once we're out and experiencing the world. Our compensations to breathe have led us to have smaller jaws. And so expanding those jaws. Myofunctional therapy, learning about the function of our muscles and what they're doing around our face. I know Dr. Ben's a huge proponent for combining that with the oral appliances. Pressure devices like CPAP, depending on how much distress the patient is in. Acupuncture, he recommends, he thinks it can be as successful as myofunctional therapy, just not as well known. He talks about that on his blog for those wondering. Slimming down, and then surgeries. So I think this is a great analogy to talk about treatments. There are so many different types. It depends on the patient, it depends on the circumstances, it depends on their goals. And so I think that's a good summary, hopefully, Lauren, of upper airway resistance syndrome, what it is, what it looks like if we're recording it, and some ways that we can treat it. So I know you told me 20 minutes. So
yeah, no,
I didn't go
terrific.
over.
We do have a lot of questions. I am going to ask you if you can, because people do like repetition. And actually, if Dr. Boyd likes repetition, he's with us tonight. So
Dr. Boyd, what's up, Uncle Kevin?
Can you go through the car illustration one more time so then it really sinks in our brains, because that was such a great analogy, and I know you hear it once is great, but let's hear it again so then we can kind of, even if you don't want to use the slide, just talk through it, but it's probably easier to just demonstrate it.
Yeah, because I'm, of course, me and Zoom again. I'm like, where's my share screen button?
But
okay, I'll try to explain it.
It's good to just reiterate and just go over it one more time, high level.
Okay, I'll try to explain it, and then if I have to pull the picture back up again, I will. So the summary is that, and there's actually a slide I probably need to show that talks about breathing as a whole. For time's sake, I got like the extra 3. If I got an extra 3 minutes,
you're good. We're good.
Okay. All right. Let me go back, because there's a couple of things that I okay. How do I start presenting? Okay, here we go.
Yeah.
Here we go. This was my analogy about how we're at parking level 1. Okay. So as we go higher up in the parking deck, we get deeper and deeper into getting to ultimately the truth of each patient and what exactly really is the issue here, which Dr. Boyd is listening, so he knows where I'm headed with things. But let me present this, because I think this will tie into this autonomic nervous system kind of whole puzzle. So dysfunctional breathing is a big puzzle. In my master's program search of just information and really getting down to the nitty gritty, I love this slide because it really just depends on who you're talking to. Each person is going to give you a different view. Oh no, if it's mouth breathing. Oh no, it's irregular breathing. Oh, it's when your carbon dioxide is low. Oh no, it's when you're breathing through your chest. There's so many different things, right? But ultimately, dysfunctional breathing is multidimensional, which makes it so hard to really put our finger on one thing. But it's biochemical, it's biomechanical, and it's psychophysiological. There's this melting point of our brain and our body where they fit together. My teacher, Dr. Litchfield, he calls it the part of your kitchen where the refrigerator and the countertop, or the stove and your countertop meet, that little crack. That's like a melting pot of where this really flows together. So in order to really get change, a lot of times for complex patients, I'm one of those complex patients, tackling this problem from like one view, so structure, doesn't really get you the results you need, because we need to tackle it from structure, function, and behavior, or biochemical, biomechanical, and this psychophysiological element. And who needs what, and what pieces are at play, and people with one disordered breathing issue may have another or may not have another. They're going to overlap. It starts to get really complex. And so those complexities, Lauren, are very important because we're kind of doing an over generalization and summary. But I'll go back to the car example.
Sure, thank you.
But I will say that Breathing with upper airway resistance syndrome when you're sleeping, the best description that I give to the patients is that your body is going to make sure that you take the next breath. It's going to make compensations to survive. All of this boils down to what are the compensations to survive. And as my friend Roger says, take the next breath. So what ends up happening is as the oxygen starts to kind of sort of drop, the heart immediately jumps in to compensate. Okay. And then because we're still healthy, we get back to our adjustment of our vagal tone and our parasympathetic. So we go sympathetic, then we go back parasympathetic, but then we go sympathetic and parasympathetic. So we're going to see these changes in our heart rate. I don't have mine to upload, but personally, I'd go from 60 beats per minute to like 120 beats per minute, and up and down, like on a roller coaster. Okay. But over time, when we get less and less healthy, it's a loaded word, but as we get more and more unhealthy, then what happens is the body knows this to be normal because this is a chronic thing. So chronically, we have this, so the body starts to realize that, okay, this is normal. My heart's not going to jump in as much in this simple example, because what are we jumping in for? This is normal. You know, it's like there's a fight in the kitchen, everybody go, and everybody runs to the kitchen and breaks the fight up. Well, after that happens 300 times, Lauren's like, hey, Jasmine, there's a fight in the kitchen. I'm like, oh, there's nothing going on. They're all right over there. And that's what happens with the body, right? The body gets used to these chronic applications of things, and we end up cycling what our body perceives as normal. And then it reacts from that new mindset of normal. So hopefully that makes sense. And what's happening with this car, and how as the overdrive of the sympathetic activation happens on this left side, that hill is changing, right? And that's why we start to see those oxygen drops. That is a super oversimplification. But
we love it. We love it, especially, you know, it's late in the evening on the East Coast. So we appreciate that very much.
Of course.
Yeah, so let's get to some of the questions here, because we have a lot of them. I love everyone's enthusiasm who's listening. So thank you for everyone for your questions. But how do you address skepticism among medical and dental colleagues around UARS?
Yeah, so I think everybody you talk to is going to have a different answer to that. For me, it's better to make a compelling offer than it is to make a convincing argument. So for me, there's no need for me to, argue with people. I just kind of present information, ask questions. Part of the problem is we don't ask questions at all, really, and we don't ask the right questions. I've found that once you actually ask questions, you get answers that make us a little uncomfortable. And it's in that zone of the discomfort that we really can get to the solution of our problems. So for example, I was in the operating room the other day doing some traditional pediatric dental stuff. And my staff and I were talking about breathing because they're fascinated. And the anesthesiologist was kind of like, trying to hint at the fact that I didn't know anything, right? Because it's all about oxygen. And I said to him, if you had to pick one monitoring system in this whole room to monitor this patient, what would you pick? And I said, before you answer, I'm sure it's the capnometer to look at the CO2. And he looked at me like, I guess you know your stuff. And now he's going to listen more because I've proven to him that I know something. I don't have to know everything, right? That's why I'm putting you guys in the direction of Stephen Park and Roger Price and the people whose job it is to give you a whole course, a weekend course, a 6-month course on all this stuff. But just to keep it simple with people, you just got to prove that you know some stuff. And from there, you're opening a conversation. And really, it's about a conversation. And when people are ready, they'll move forward. But as you know, Lauren, those people who need our help most want it the least. So it's easiest to make a compelling offer than it is to make, this argument, this convincing argument about why they should move forward or why you should know this or why you should listen to me. That's how I do it. Yeah.
You need your energy, right? You have to save that energy. I'm just going to go back to that analogy because there are a couple more questions about that. Can you define HRV in comparison in the analogy that you just gave, like compared to heart rate per se?
Yeah, so heart rate variability is its own topic. There's a really big movement in something called heart math. There's ways that can be monitored. For the purposes of the high resolution pulse oximeter, we're looking at changes in pulse rate or heart rate That's not the same as heart rate variability, which is being monitored in some dental offices and medical clinics. Is like a totally different thing. I don't have enough time to get into heart rate variability.
Right.
Then I got to go into electromagnetic radiation. It's just a bunch of different stuff. But for the way that probably the audience, I can't see the questions, but the way they're probably thinking of heart rate variability and the way that it is monitored, you have different zones of what's healthy and unhealthy, like how you have LDL and HDL for cholesterol. Heart rate variability has different colored zones of what's like, that's way more a little complex than what we're talking about. The bottom line is on that high resolution pulse oximeter, you're going to see changes in someone's heart rate that are happening frequently and in a big range, where when we're sleeping, our pulse rate or heart rate should be very calm and very stable. Yeah, I think that's the best explanation. Heart rate variability, I love, and that we'll go down a whole nother rabbit hole then.
For diagnosis for UARS with small nostrils, how do you measure that? Example, what is normal nostril diameter, say, for a 4-year-old?
So I am not an ENT. I'm not an ENT specialist. I probably cannot give you, and I'm one of those people where I'm not going to make anything up for you guys. But what I will say is, you can notice what would look like a collapsibility. So like if you look at the nostrils, at least just recognize that there's a normal circular shape, and then there's people that have this cylindrical shape. And unless this is an ENT asking this question, you have to protect your license. We cannot diagnose, a deviated septum, collapsed arches. We want to be very careful in how far we go with the diagnosis per se, but just kind of as we're observing our kids, look at several family members' noses and nostrils and look at the variation, and you'll see as we get a little smaller. I think that'll help as far as the anatomy goes. But Lauren, I want to point out that whether we're small or large, we want to focus on the function, right? How does the nares actually, how does that work? How does that system work? More so than the size, I think. And if you listen to that podcast that I took the bullet points from, Dr. Gimeneau goes into a little bit detail with Dr. Park about more of it. So I think in context, it'll kind of resonate a little bit better. So I apologize for taking that, I guess, out of context and focusing on the nostril size.
Don't apologize to us.
Yeah.
You're awesome. Never apologize to us. You're giving us your free time and your knowledge, and we're very grateful. Why is this more common? Well, usually with thin women who exhibit UARS. Why does this seem to be like a syndrome for thin women? That was one of the questions.
Yeah, so the airway, I just love Rogers Court. I'm going to give you all these resources, Lauren, so you can.
Yeah, and I'll send them in the follow-up, so people don't worry.
Perfect.
Everything that we're referring to will send up in the follow-up email.
Yes, so you guys, and feel free to DM me on Instagram, rich_sleep. I'm happy to share a bunch of different stuff. We can Zoom, all of that. Lauren, ask me the question. I lost the question. Ask me one more time. I'm sorry.
No, it's about thin women. With,
yes. Thank you. So what Airway Health Solutions actually has a lecture on is how, from the gestation process of how we're born and developed, our respiratory system, our body as a whole, the respiratory system starts about 4 weeks or so in utero, and that whole process of development, right? Somewhere along the lines, as the generations have gone on, we're getting smaller, whether that's because our function is not as good, and function and form go together, whether that's because of the toxins in the environment or whatever reasons. What's happened is everything's getting smaller, okay? And so as our jaws, as our bodies compensate to that, remember, everything's a compensation to breathe, our posture changes, and our airway is not just the nose, the ENT airway, the mouth, the dental airway. There's a whole nother area of our lungs, lung capacity. What happens when we use our diaphragm and breathe with our diaphragm versus when we breathe with our chest, how our lungs will insert that oxygen, right? So I don't know if people know this, but if you breathe with your chest, the oxygen is only going in the upper 2/3 of your lungs, versus when you breathe with the diaphragm, the oxygen is able to reach the very base of the lungs. I didn't know that originally, right? So when we're talking about the airway, it's all of it. It's not just the nose, just the mouth, just this whole complex of our thorax, it's the whole thing. And so with the skinny, thin women, what's happening a lot of times is that they have small jaws, right? There's some myofunctional therapists, I can finally see the comments now that are in here, and they would argue that the tongue is getting trapped in the middle and the tongue is causing this autonomic nervous system, overstimulation. And when they take those sleep studies, whether they be at-home sleep studies or in-office sleep studies, Lauren, their oxygen saturation is not dropping. They don't fit into that normal mold of obstructive sleep apnea. I remember my stepdad was told that because he was, a big fat man with a fat neck, he's classic, sleep apnea, body. And it's one of those things where if we're thinking that that's the only people that can get obstructive sleep apnea, then we're not screening the other people. We're not asking those questions, right? We're not asking about sleep. My doctor never asked me about how I sleep. I walk in with bags under my eyes and a coffee in my hand. They never asked me any questions about my stress levels or how I'm adapting to my environment. And so a lot of the skinny women get overlooked because we compensate so well. We compensate for the fact that our jaws are small by adjusting our posture. We compensate for the small ability to breathe through our nose by breathing more aggressively and having a bigger effort. So we compensate. And because we're not fat and out of shape and we don't have diabetes and all the other problems, we get overlooked. And so that's why I think, Lauren, hopefully that answers the question, that because we make all these compensations, the normal people get overlooked, and we have to change the definition of what normal is,
Absolutely. Is it possible to have less UARS by losing weight? Is there any data on that? Is it a direct correlation?
Yeah, so there's the studies say if we're, again, in that definition, right? And definitions, I didn't say this earlier, but definitions are man-made. Dr. Gimeneau says this in the podcast that you guys definitely should check out, that we have a descriptor. It helps us communicate. It helps us all know what's going on, but descriptors are limiting, right? So in the sleepiness example, can we get better at the symptoms of upper airway resistance syndrome by losing weight? Of course, in theory, yes. But if we look at upper airway resistance syndrome and as a whole and everything that it is our inflammation really decreasing? Are we still breathing really aggressively through our nose and having that respiratory effort, even though we lost weight? We'd have to see. I argue a lot of times that we fix kind of the surface things, and the undersurface things, the lower levels of that iceberg are kind of still at play. But what we see is an improvement. And as long as the patient feels an improvement, honestly, fantastic. But usually the other symptoms and things are still at play.
A lot of the questions are kind of a similar theme about the best solutions. What is your favorite way to help treat UARS?
Oh, guys. Oh, you're getting juicy. All right. So, all right, I'll give you a good doctor answer. And I would say, as a dentist, it's an oral appliance, and get the jaws wider and start as early as possible and start with kids. My new office and the new things that I'm working on that are launched in 2022 are all with adults, because all the moms and dads and grandmas and aunties and cousins and neighbors who bring these kids into the office to see me are suffering, and nobody seems to care about them. And so I just decided I'm going to kind of pay attention to these adults. So for them, we could say an appliance. I think a fantastic one is the appliance by Airway Health Solutions. No, this is not an ad. No, they're not paying me. But I think that it's a great balance of having a system. You need a system in a dental office. You need something that's replicable. You need something that works. You need something that the patients are going to understand the process. Your staff members are going to understand the process. And you need something that's going to get predictable, reliable results. I think that does that without a huge 5-figure investment up front. Unless, Lauren, you've changed that recently.
No, we're never changing that. And I never say never.
So I really like Airway Health Solutions. And so yeah. Now, my Jasmine Elmore answer is, for me, there's 4 things that I like to focus on that are hugely important to getting someone to feel better. Because I found that until someone actually feels better, selling them on a big plan is a lot. It's overwhelming. And though you may convert them, I find that they burn out very quickly. So for me, the first thing is calming the nervous system. There are many ways to do that. But as a breath specialist, I focus on breathing in ways that we can calm the nervous system. And a lot of times the things that are going on around us, our relationships at work, our relationships at home, there's always going to be stress. But our response to that stress, if we don't fix that, Lauren, I'm telling you right now, that all of the anatomical and structural changes we make 5 and 10 years out, they start to relapse because the body is just not right. We're not balanced. We have to calm that nervous system. We have to keep our balance of parasympathetic and sympathetic. We cannot be stuck in sympathetic overdrive forever and expect to be successful in any therapy. So that's the first thing. The second thing is unlocking the neck. So for me, my big problems are with my neck. My neck is locked up all the time, whether it's chiropractic, PT, osteopath. When this bite is not properly balanced, my neck gets locked up. So finding ways to unlock the neck. And that can be with a stabilizing appliance. That could be with your expansion appliances. That can be with some other things that we won't get into, but unlocking the neck. The other thing is relaxing the muscles. The facial muscles play a big role in our function. I'm sure you sleuths out there have seen my mentalis muscle firing. As someone who's tongue-tied and working on myo, the restriction in the facial muscles and the tension plays into this as well. And then balancing the bite. I call that curb. So that's what one of my new programs is about: calming the nervous system, unlocking the neck, relaxing the muscles of the face, and balancing the bite. And once someone is at a state of balance and restfulness and feeling great, now I like to take the deeper levels of deep diving into the appliances and the bigger treatment plans if we need them. And now we can really start moving because we have momentum, we have confidence, we have accountability as we start at the more conservative levels. So that for me is how I treat things, but I'm also very holistic. And people will ask me, well, how do you make money? Stay tuned in January. We talk about that, how you make money with that. But it really is about having your patients see the value in their problem. You know, somebody that wants to pay you $200 for a problem, Lauren, means they think their problem is a $200 problem. And so, you know, for me, I know my practice, I have $1 million pediatric dental practice that has to run. So for me, just in that one practice, I have $1 million problem if I don't fix my airway issues. So a $5,000 treatment plan in the grand scheme of things is nothing, because I understand the value of my health and what it means for my health to be great. So I think for a lot of us, it's getting our patients to understand what this means for them. And then from there, again, you're making the compelling offer, not the convincing argument. It's very easy to sell airway health solutions or whatever, Vivos, whatever you're doing, as long as you get them to understand that buy-in point. So that's my complicated answer of what works for me for resolving upper airway resistance.
No, and I'm a big fan of acronyms, so I love that, the curve. But can you kind of focus a little bit on the myofunctional therapy part? Mm-hmm. How do you include that in your practice?
Yeah, so right now I outsource my myofunctional therapy. I've got a patient who works in China part-time and travels all over the world, and he cannot sit in the office and do myo. And I'm someone who's always thinking about, okay, it's 2022 coming up, but it's going to be 2042 soon. And I'm 33, so I'm still unfortunately going to be working. So how do I bulletproof or move my practice into the next, couple decades? So for me, I really focused on trying to maximize Zoom. I have a couple of providers of myo that are great. They all have different strengths. And because it's a habit modification, you need a good coach. So I think of it as, going to the gym. My trainer, he's a super buff guy that likes to yell at me, but my fiance doesn't want anybody yelling at her. We have two different preferences. So I match my patients to the myofunctional therapist that I think balances with their personalities the best. But myofunctional therapy is huge. How we use this new jaw we make, how we breathe, how we eat, how we function is super important. And the muscles around our face support that, right? And that attaches to the neck and the spine, and all of it is one piece. And so I think myofunctional therapy is a big deal. I will say that when the muscles are not relaxed, though, myofunctional therapy is not the best option. So for me, I had to go through a whole process with an osteopath to relax my muscles and again, calm my nervous system, because my body was just not, ready for myofunctional therapy. Now I am, and now I'm doing it. But at the beginning with super tight muscles and sympathetically just big ball of, bound up tension, my body didn't respond very well to myofunctional therapy and what it wanted to achieve. But myo's fantastic.
Someone just chatted, is there a quick tip on calming the nervous system? Is there such a thing? Go ahead, great.
Oh my goodness, there's so many of them. A lot of
Okay.
people like Buteyko breathing. Just outside of anything that complex, you want the exhale to always be longer than the inhale. That's the quickest and easiest thing that I tell people when I'm working in my traditional pediatric dental office and kids are stressed out about their visit. We go immediately to their breathing and it changes things for them. So for the kids, we do 3 breaths in, 4 breaths out. For myself, usually I do 4 breaths in, 5 or 6 breaths out. But focusing on the exhale, that's an oversimplification. But it doesn't work for everybody because breathing really is personalized and unique. There's some people who their issue is the inhale, not the exhale. But for most people, they're not focusing on the exhale. The body, for whatever reason, is moving too fast and starving for the next breath. So the exhale is very short. And so that can usually stir up some anxiety feelings in the body. So keeping that exhale long seems to help. So for the kiddos, I use 3 breaths in, 4 breaths out, and that seems to help them pretty well, pretty quickly.
How do you explain to patients the difference between UARS and sleep disordered breathing?
Yeah. Let's see. Usually I say that sleep disordered breathing is this big umbrella, right? And Upper Airway Resistance Syndrome falls under that umbrella. For me, it's actually breathing disordered sleep. And the reason that it's breathing disordered sleep and not sleep disordered breathing is because I'm not a sleep doctor. So I don't have to worry about someone coming for my license. I can talk about breathing. We can talk about education. Today, we just talked about education. There are ways that in another conversation, we can talk about how you can test your body and see how well you're breathing by hooking yourself up to a capnometer and seeing your breathing moment to moment. It's education. So I focus for patients on the fact that what happens in our sleep happens during the day. We just don't have the awareness yet to notice it. And so there's this big umbrella that is sleep disordered breathing or breathing disorders of sleep. And then upper airway resistance syndrome is one of those things underneath. A lecture a couple of years ago, I don't know if Dr. Zaghi has updated his slides, but he had this great slide of like a little figurine in front of some dominoes. And at the beginning of it was snoring. And then it would go to mouth breathing mouth breathing first. Then it would go to snoring. Then it would go to upper airway resistance syndrome. And then there'd be obstructive sleep apnea and like this fireball emoji thing, or where Dr. Berry calls it roadkill at that point. Just to kind of emphasize that you're going on this journey and like the end stage of it is obstructive sleep apnea and the beginning stages are like audible breathing and mouth breathing. I think those are like the simple ways that you can use to kind of describe to patients, what is this big umbrella, what's falling below it? And then from there, individualizing your methods to figure out where they fall on that spectrum. Did I answer that? Hopefully,
Yeah, that's a great answer. I'm
that.
trying to, because you're answering a lot of these questions as we go, but why does UARS get worse with age and then level off?
Yeah, I saw that question. I'm not sure it ever levels off. I think a lot of times what happens is we get really comfortable. Our body gets really comfortable and we compensate in a way where things aren't noticeable anymore. The example I gave recently to a parent that she loved is that a lot of people stopped going back to work, right? During this COVID, the pandemic happened and then we reopened and people stopped going to work and people said it's the pandemic. And I argue that people were unhappy before the pandemic, right? We just were comfortable. They didn't really seem like a way out. And these problems didn't just start all of a sudden. We really took a look in the mirror and looked at our lives and went, holy crap, I'm not necessarily happy. So in that analogy and how I used it with this mom, back to upper airway resistance syndrome, I'm not sure we really get to the point when you leave something unaddressed that you just like flatline and get better. I think that you're at this comfortable state and then something happens where all of a sudden it's like, oh, there it is. There's that thing again, but it was always there. Other things have happened where the symptoms that you did experience fell away, but there's other symptoms now that we haven't noticed and they're kind of resting below the surface until they're not below the surface. So yeah.
And then what percentage of physicians accept UARS as a diagnosis?
I'm not going to be able to answer the numbers. I'm not 100% sure. I know that UARS was developed by Dr. Gimeneau, and Roger shared with me an article that came out in 2020 that I can share with you, that basically talks about AHI and how these definitions are falling apart. And I'll just go back and say again, these are things that are in a box. They are definitions. I don't need to go see someone rob an old lady on the corner for me to know that old ladies get robbed on corners. You know, for me personally, I don't need a definition for me to know that something's saying danger and here's how you define it for me to know there's danger. I understand that for a lot of people, they need a definition. They need upper airway resistance syndrome and sleep apnea for them to know that there's a breathing problem. For me, I don't need those definitions to know there's a problem. And that if my patient comes to me with, hey, I have an issue, if I look at what they have going on and stop trying to fit them into a box, then I probably can resolve their problems a little bit easier. But I understand, again, we run businesses. And if you want to run a good business, you got to bill. So you need things to fit into these boxes and these bubbles. And so, you know, how many doctors accept it? I can't tell you, but a lot of the sleep doctors are using this terminology. And like I said, with Lauren, I'm going to give her about 15 different resources in some categories that you guys can look at, from low price point to high price point. 4-hour course to weekend course, you know, a bunch of different things. If you want to go complex and surgical, or oral appliances and airway health solutions in the middle, or holistic and changing breathing like what I do, I'll just give you guys a bunch of resources and I'll have them for you, Lauren, by Friday. So you have
Great,
them to release.
we'll take it. So last question, and then I'm just going to do some updates. Do you find any value in pediatrics for the pharyngometer and the rhinometer?
A lot of my friends use that technology. I don't personally use that technology for a variety of reasons, but mainly in my kid's office, I don't have a pediatrician. It's in a rural area. I don't have a pediatrician yet that's necessarily on board with, you know, giving me some backup as I find an issue or problem. You need to pass it. It takes a village. You need a collaborative team. So for me, we stay kind of in those holistic ranges and realms, but I have a really good colleague of mine who uses every monitoring system you could think of that measures every possible thing. And he swears by all of them. So yeah.
We're actually going to be having Dr. Brett Christensen on our conversations in 2022, early 2022, and he'll go over the cases that he uses this technology. So stay tuned for that. I'm just going to go ahead and share some updates, if I can just get my share screen here, of what's coming up and also how people can contact you. Jasmine, I know you said you wanted to just do it through Instagram. They can DM you here. You can see my screen, right? To see the at Rich.
Oh, yeah, I can see your screen.
Sleep. Okay, perfect.
Rich _ sleep. Send me a DM and then I'll send you my phone number. We can text, we can hop on Zoom. Happy to talk to anybody, you know, just for free. We can have more of a real talk behind the scenes, give you my personal opinion on whatever you want to hear.
You're amazing. And if anyone who wants to learn more, we do have our mini residencies. Our adult one is actually this Friday. We have 2 more spots left if you're interested. If not, consider joining us next year in January and March. I know, Dr. Elmore, you took our mini residency and we loved having you and really appreciated your feedback on that. So please consider either reaching out to me or going to the website. We are thrilled to have Dr. Kevin Boyd. I know he was with us this evening. I don't know if he's still on, but we are so thrilled for the early childhood curriculum, and he's so passionate about preventing malocclusion, preventing sleep disordered breathing, that we're going to make a whole curriculum based on that, starting on December 10th, just with risk assessment, and then January 14th, how it's really enjoyable to treat kids. So really tips and tricks and techniques to help you move forward with treating children in your practice. So please feel free to reach out to our website, reach out to me personally, happy to chat more about it. We actually offer a myofunctional therapy course geared towards the dental hygienist to do myofunctional therapy in the dental office, but also for practicing myofunctional therapists who want to learn more and integrate and learn Brittany Sierra and Carice Laguerre's tips and tricks that they use really to take maybe their myofunctional therapy to the next level. So it's good for beginner, advanced, all levels. Check us out at airwayhealthsolutions.com/myo. You're on our map, right, Dr. Elmore? You filled this out, I hope, because you're in North Carolina here. If not, you got to get on the map. But once you take our training, we do invite you to become part of our locator, because I am asked daily to find airway dentists in the country. And actually, we're going to update this map with even more green dots. And once you take our course, you have access to the Airway Dentist Facebook group, which we hold private events, and really like going to roll up our sleeves and have some really great town hall discussions. In fact, anyone who is an alumni, we have our town hall tomorrow with Dr. Ben Moralia at 8 p.m. So either join us on Facebook or register through the link we sent you. We have another upcoming Airway Health Solutions conversation this year with Dr. Gerald Simmons about screening, monitoring, and management of OSA. So it's a perfect segue from tonight from the dental chair. And then January 5th, Dr. Ben Moralia will be doing an airway dentistry and overview with co-host Dr. Hal Stewart. So we're going to invite the Hal Stewart group as a study club to join us in the beginning of the year. So here is our contact information, and let me see if anyone has any additional questions. Everyone wants to thank you, Dr. Jasmine, for an amazing presentation. So thank you so much.
Thanks,
we really
everybody.
enjoyed having you. Hope you come back again in 2022. There's so much to talk about, right? We can just.
I know there is. I did see
any
one
advice
question,
you
Lauren.
have?
Oh, I was just going to say, I did see one question about
Sure.
a patient that was feeling like they were suffocating and different things. And so what we didn't get a chance to talk about, and again, in the resource that I'll give you for Roger Price's information, he talks about how we measure breathing through a lot of objective measures, right, which is great, but then there are these subjective measures, because breathing is psychological, breathing is physiological, breathing has different elements. And so depending on where each patient's issue is, maybe it's more so in the psychological elements. We need to kind of take a behavioral approach and take a behavioral inventory of what the person has going on, make those changes, and we'll probably see some improvement. So there's definitely different elements to it. We had a super quick chat here, but I'm happy to chat with anybody else about some other things.
Great. Well, we're at 9 o'clock. I do like to be mindful of your time and everyone else's time. And I want to thank you, and thank you everyone for your continued interest. Hopefully we'll see you December 1st, and I will send the follow-up email by Friday with all the information that Dr. Jasmine has graciously shared with us. So thank you, everyone. Thanks, Dr. Jasmine. Have a great night.
Bye, Lauren. Thanks for having me.
Take care. My pleasure. Thank you.